So he was apparently, well, 2 days ago, he started developing all these complaints of numbness and weakness over the left upper and the lower limb. Relatives noticed his speech was a little bit slurred when he was trying to talk, and he also had a complaints of double vision when he was trying to looking at the left side. He also had a complaints of difficulty in walking. Previously was not need any assistant to walk, but in last 2 days he need assistant to walk. And other history wise, there was no complaints of blurring of vision, no complaints of drooping of eyelids, no complaints of loss of consciousness or seizures, no complaints of chest pain or any palpitation, no bowel or bladder incontinence. Past medical history wise, significant diabetes medical history was there for 25 years with a poor compliance with medication. Hypertension for past 5 years on medications. I had a toe amputation, multiple toe amputation on the leg in 2022, and secondary to the diabetic neuropathy and ulcers. A significant past history of smoking history was there with the 10 sticks per day. For past 20 years, he used to smoke. On examination, on arrival to ward, he was conscious and comfortable on the room here. Vital signs with blood pressure of 130 over 80, heart rate was 8, pulse rate was 80, which was regular, and respiratory rate was 18 with a temperature of 98. There was no pallor, icterus, clubbing, or edema. Respiratory examination and CVS examination was insignificant. Abdominal examination also was insignificant. And CNS examination, higher mental function, he was oriented to time, place, and person. Speech was slurred. And cranial nerve examination, there was a right-sided adduction restriction he had, and the pupils were equal, bilaterally reactive to light. Left abduction horizontal nystagmus was there, and which was worsened when he was trying to see it on the left side. And on the facial sensation, there was a subjective findings of facial sensation, which was reduced on the left side compared with the right side. Gag was present bilaterally. Other cranial nerve findings was normal. Motor power 5/5 in all 4 limbs at the time of examination. Reflexes were 2+ all over the joint. Sensory, there was no other sensory deficit in the body. Cerebellar sciences, he had a left-sided dysdiadokinesia, was not able to do the do the alternative hand movements. And this is a video of his eye findings. So when we asked them to see it on the left side, he was trying to see it on the left side, but only there is a left eye moving on the left side. The right side is having the adduction palsy. And whenever he is trying to see on the left side, there is the abduction nystagmus he is having. So he was not able to try to look at on the left side for a long time. So the clinical diagnosis we made after the history and the examination, he presented with the left-sided weakness with the diplopia and the left cerebellar signs. On examination, there was a right adduction defect with the left abduction nystagmus. So more of posterior circulation, probable medial pontine region, stroke in the pontine region. Vascular territory-wise, paramedian or circumferential branches, which are predominantly supplying from the basilar artery, which are predominantly supplying the pontine regions. So the initial differential we consider after the history and the examination, initially I thought it was a Weber syndrome because of the ipsilateral eye findings with the contralateral hemiparesis. But there was then after the read-up, we found there was one thing called Raymond-Sisson syndrome, which was present with the rostral pontine stroke, which will have the cerebellar contralateral cerebellar signs also, along with the left-sided weakness and the INO symptoms. So pseudo-INO, which was it was unlikely in this patient, which was most commonly with the myasthenia and the GBS patient, and progressive supranuclear palsy was not is less likely in this patient since he does not have any other features of PSP. Other INO mimics like idiopathic intracranial hypertension also was ruled out. This one, fundus was checked, there was no papilledema. Orbital metastasis is one other common differentials when we have eye findings with a primary on other parts of the body. So the initial investigations were done, which shows us a normal HP with a WBC of 11,300 with a platelet of 2,72,000. Other findings is ECG shows sinus rhythm, LV gush, and the long-standing suggestive of long-standing hypertension. Echo was done, which shows LV gush with grade 1 diastolic dysfunction. HbA1c was 10, which shows a poor control of diabetes mellitus. Holter was no arrhythmias. Lipid profile was fairly okay, and MRI was done, which shows there is a ischemic infarct in the lower midbrain to pontine infarct. So most of the rostral part of the pontine region. So I'm going to talk about this internuclear ophthalmoplegia, which is our patient predominantly present with on our findings in the examination also. So it's an inability to perform the conjugate lateral gaze and ophthalmoplegia. Medial longitudinal fasciculus is affected in this condition. MLF is the one which will connect the cranial nerve 6 nucleus and to the cranial nerve 3 to make the lateral gaze smoothly. And Pons, more dorsal eye signs will be present, more ventral infarct, eye plus motor signs will be present because of the presence of CST. So this is the internuclear ophthalmoplegia. So whenever there is a frontal eye field, which will give the signal to the paramedian pontine reticular formation, and the paramedian PPRF will give the signal to the ipsilateral cranial nerve 6 nucleus. Then the ipsilateral cranial nerve 6 nucleus will give the signal to the contralateral cranial nerve 3 nucleus via the MLF. When there is a problem with the MLF, the ipsilateral adduction, the ipsilateral cranial nerve 3 ipsilateral cranial nerve 3 function will get lost, and there will be adduction palsy on the ipsilateral side. At the same side, patient will develop the abduction nystagmus on the other opposite side because the patient is trying to overcorrect the condition. So what are the risk factors present with the INO? So mostly whenever the young patient present with the INO, predominantly it's a multiple sclerosis, but in the elder patients, CVA is one of the common cause with a history of vascular risk factors like hypertension, diabetes mellitus, and smoking. Smoking is one of the common history which our patient have. And other rare cases are bacterial meningitis, syphilis, TB also can cause inflammations like sarcoidosis, SLEs, and trauma like head trauma, and metabolic conditions like hepatic encephalopathy, Fabry disease, other conditions like subdural hematoma, hydrocephalus, and supratentorial arteriovenous malformations. So rule of 4 that we know, the medial structures are more of a motor nucleus, motor pathway, and medial longitudinal fasciculus and the medial lemniscus, and the lateral was sensory. Our patient had a MLF involvement, so suggestive more of the medial infarct in the that's a localization is also on the medial pontine region. And the one slide about the Raymond-Sisson syndrome. So with the findings in our patient, he had a ipsilateral INO, he had a contralateral cerebellar signs with dystoidochokinesia, had a contralateral decreased facial sensation, but was very subjective, and a contralateral hemiparesis he had the CST involvement. So with these findings, we thought initially of the Raymond-Sisson syndrome, which was predominantly on the rostral lesion in the pontine segment and the base. So more common causes wise, stroke, brainstem tumors, or tuberculosis. In our patient, he had a CVA. In our patient, I was diagnosed with a cerebrovascular accident, posterior circulation stroke. He was started with DAPT for 90 days, followed by SAPT. He was his OHAs were optimized during the ward stay, and he was advised to have a strict glycemic control and to stop smoking. And he was regularly following up on OPD, and his INO is improving, and other signs of numbness and everything is also improving.
Thank you, Dr. Brightus. I think it's a very interesting case. We often read about INO and Weber and Raymond question, but good to see the case. Any questions from the audience or people on Zoom? Any comments? If